see. We were discussing about dysmenorrhea, so might as well finish about dysmenorrhea just now. So dysmenorrhea can be a primary dysmenorrhea see. We were discussing about dysmenorrhea, so might as well finish about dysmenorrhea just now. So dysmenorrhea can be a primary dysmenorrhea where the pain starts half an hour prior to onset of periods and stays 10 hours post onset. Now that's the pain of the primary dysmenorrhea, also known as the spasmodic dysmenorrhea. Okay, primary or spasmodic dysmenorrhea. Now that's the dysmenorrhea all women have. You know, any woman who's getting periods, she will tell you that around half an hour to 1 hour before the onset of periods, she'll have this pain which is going to become sharper and sharper, and she'll say, I think I'm going to get my periods. And when the period starts, that first 10 to 12 hours, the pain will be very, very severe. And after that 10 to 12 hours of pain, the cervix will open up and the blood will start to come out. So first day of pain, second day of bleeding, third day of getting over. Perfect period to have. And that's the pain all normal women have in their periods. That is known as the period pain of all normal women and of women with fibroids uterus as well. Now your Shaws will confuse you sometimes. They'll say that fibroids have got congestive dysmenorrhea. Yes, it can happen when there is superadded infection or degeneration, can happen that way also. But classically fibroids and normal women have a primary or a spasmodic dysmenorrhea. Now pain starts 3 to 4 days prior, and that stays throughout the menstrual cycle, throughout menses. Now that's a very, very severe pain. Any woman who's getting period, let's say on 16th of August, pain starts on 11th of August, stays till 16th, and when the periods start on 16th and stay till 21st, all these 5 days also she's got pain. So 5 days of premenstrual pain and 5 days of menstrual pain, that's a very, very severe dysmenorrhea. We call it the congestive dysmenorrhea, or we also call it the secondary dysmenorrhea. Okay, that's what you see classically in cases of PID and in endometriosis. PID and in endometriosis, that's where you see this severe pain. So these are the two types of dysmenorrhea you see. There's another one which is slightly more complicated, but I'm sure you'll understand. What is that? That's the membranous dysmenorrhea. What is a membranous dysmenorrhea? Now, if you recall, the menstrual blood which comes out from the uterus, what is the form of this menstruation? What is it? Is it liquid or is it semi-solid? It's liquid, obviously. So menstrual blood is liquid, but hello, it is blood, isn't it? It's the glands which have shed, and there'll be a lot of blood in it. And I think blood should clot. So menstrual blood should be a clot, isn't it? Fortunately, it's not, because the blood which trickles down, which sheds off in the uterine cavity, this uterine cavity itself has its own fibrinolytic system. There's a very important fibrinolytic system of the uterine cavity itself. So whatever blood is there, it is not allowed to clot. It stays in a fluid form. So that blood which collects here, it's in a fluid form and it comes out of the uterus with a few contractions. It causes some pain, but the cervix opens a little bit and allows the blood to come out. Imagine if the bleeding is too much. Sometimes women come to me and say, sir, I'm bleeding a lot. Okay, I'm so sorry, let me examine. Sir, I'm in fact bleeding so much that I'm passing a lot of clumps. I'm passing clots, you know, when they want to emphasize, sir, I'm bleeding too much and I'm passing clots. Now, as a gynecologist, I also understand passing clots, that's a lot of bleeding. Why is she passing clots? Because the bleeding is more than the fibrinolytic system can dissolve. So yes, sometimes they do have these big clumps in the uterine cavity because of the bleeding is too much. Now imagine when this has to come out, you can very well imagine the cervix will have to open much more to allow this clot to come out, and that's why it is going to cause much more pain. Now what's worse, when there is sometimes there is a total absence, yes, total absence of the fibrinolytic system, total absence of the fibrinolytic system. So what happens, whole of this menstrual blood will now collect in the uterine cavity as a cast of the uterus. Yes, it will collect as a cast of the uterine cavity, like this it will collect. Yes, there's a cast of the uterine cavity, cast in the shape of the uterine cavity, like this. See this? So in the shape of the uterus, the whole endometrium blood is collected. Now imagine when this has to come out. When this has to come out of the uterus, this uterus will have to open a mighty big size to allow this clot to come out of the uterus. Can you imagine this? This uterus has to open this much. So to open this cervix so much, to allow this such a big clump to go out, the uterus will have to undergo a lot of contractions and much more pain. So yes, when there is a total absence of the fibrinolytic system, the endometrium is shed like a cast of the uterine cavity. The endometrium is shed like a cast of the endometrial cavity. So that's what is the membranous dysmenorrhea. Membranous dysmenorrhea. Fortunately, it's very rare. Thankfully, it's quite rare. But yes, it does happen. You know, you'll be surprised to know I've been teaching you postgraduate entrance students for a very long time, ever since 2003, I think. And in this 15-16 years, I actually saw this only in 2009. You know, I've been teaching you since 2003, and I saw this case for the first time only in 2009. A woman comes to my OPD with a fleshy mass in a polythene bag, and she says, "Sir, this came out of my body today." And I'm looking at it, and it's like a triangular big fleshy mass, and I'm looking at it, and it looks like a cutlet actually. And I'm like, "This came out of your body, and you must have had a lot of pain." "Yes, sir." "Are you bleeding a lot?" "No, sir, I'm not bleeding at all." So it doesn't look like anything to me, which I've seen earlier coming out of a woman's body. So I examine her, open the vulva with a speculum, I examine the vagina, I examine the cervix, nothing is wrong. She's not bleeding anymore, in fact. So the least I can do now is, of course, the woman went home, I send this for a histopathological examination. And after 1 week, when the patient is in the OPD, she has a report in the hand. And you know what is written in that report? Menstruating endometrium. And I'm like aghast. That was a fleshy mass I sent, and the pathologist is reporting a menstruating endometrium. So I ring him up and ask him, "Hey, hello, what did you report? Menstruating endometrium? I sent you a fleshy tumor." And he's asking me, "Hey, Vij, do you know something called membranous dysmenorrhea?" I know membranous dysmenorrhea. I've been teaching it for the last 6-7 years. It's the time when the whole endometrium blood sheds off like a cast of the uterine cavity. That's what is membranous dysmenorrhea. He tells me, "This is that." Yes, this is that one. And I'm like, oh God, I never realized that this is such a big tumor, which actually is not a tumor. It is actually just a clump of the menstrual blood. So fortunately, it's quite rare. All right. So let's move on and see what you can do for the treatment of dysmenorrhea. How do you treat dysmenorrhea? Very simple exercise here. The first line drugs are always the NSAIDs. And you know the NSAIDs you're going to give are the ibuprofen and the naproxen, ibuprofen, naproxen sodium, or even the mefenamic acid. Now this mefenamic acid is the best friend of girls across the whole world. You know, it is sold as Meftal-Spaz. You know, a lot of classes where I ask, what is the drug you want to give? The whole class would roar that Meftal-Spaz. You know, the whole class would scream together. Yes, Meftal-Spaz is the best friend of girls across the whole world, and mefenamic acid has got good propensity towards the uterine muscle. We know that. But yes, NSAIDs, apart from that, you can also give the antispasmodics. What are the antispasmodics? The dicyclomin, the drotaverin, and the hyoscine butyl bromide. You know the pharmacology better than me, I'm sure. So you can give the NSAIDs, you can give the antispasmodics, you can also give the combined oral contraceptive pills. Now what would they do? Why would OCPs work for the treatment of dysmenorrhea? So let's think, why do we give OCPs to some people? A woman gets married and she comes to me that, sir, I don't want to have children for the next 2 years of my married life. So I say, okay, fine, you take the OC pills, you will not conceive. So what happens when I give the OC pills to them? Yes? Why they do not conceive? What actually does not happen in a body? Yes, when you give the OC pills, she does not ovulate. See, I'll be telling the mechanism of action of OC pills myself, we'll do that. But yes, when I give the OCPs, she does not ovulate and the cycle becomes anovulatory. So anovulatory cycles are painful or painless? Yes, they are painless. We are using that, what we discussed just now. These cycles are anovulatory. That's why they are painless. You can also dilate the cervix. Yes, you can do a surgical dilatation of the cervix. Surgical dilatation of the cervix. So yes, I said I want to dilate the cervix surgically. So how can you do that? If you look at the cervix, especially in a young girl, it's a very long cervix. And that long cervix takes a lot of contractions to open. So if you can physically dilate this with a dilator, the cervix would become something like this. It will be a much easier cervix to allow. See, this cervix is now much more open. So it will allow the menstrual blood to come out much easier with fewer contractions. So surgical dilatation. Now, not many young girls would come to you for that, especially when they're not sexually active, isn't it? So it is one of those reserved things which we have. It's not a very common thing which we do. But then yes, I can tell you one line based on this, that suppose a woman delivers, suppose a woman who is pregnant, she delivers, and she has delivered a baby, and after the delivery, what is the size of the cervix? It will always be a little patulous, isn't it? The cervix is so tight and long. Now in labor, it opens almost how much? 10 centimeters. And then it will never come back to the pre-pregnant tight and long cervix. It will be a little patulous, isn't it? So yes, why does the cervix open 10 centimeters? Because the biparietal diameter of the baby, when the baby's head has to go through the cervix, the biparietal diameter is 9.5. So the cervix has to open more than 9.5. That's why it is 10 centimeters, we say. So when the cervix opens 10 centimeters, then it will be always a little patulous. So yes, I can tell you one more line regarding this, that yes, you can dilate the cervix for the pain to be less. I can tell you one more line, that Paris women have lesser spasmodic dysmenorrhea. Yes, that line we can understand now, because Paris women, the ones who have delivered, the cervix will always be a little patulous, and the pain required, the contractions required to open the cervix will be much lesser, and the bleeding will be much easier. What else we can do for the treatment of dysmenorrhea? You can do the presacral nerve ablation. You can resect the presacral nerve. The presacral nerve has the hypogastric plexus. So that hypogastric plexus, you can do a laser or a thermal resection, and that will, if you cut the pain afferents, the presacral nerve takes the pain afferents to the brain, so the perception of pain will be much lesser. You can do that. The place of this doing by laser or thermal, it has got its controversies. I'm just telling you the basics, that it can be used, but yes, a lot of people say this is too drastic a measure. But you can also give something else like the GnRH analogues. They will stop the periods. How they will stop the periods, we'll discuss about that, but that's the basic action. So yes, this is a drastic measure again, that you can stop the periods of a girl from happening. So obviously when there's no periods, obviously the pain is not there. These are some of the drastic measures we do. We stop the periods for 6-7 months sometimes. But yes, these are the measures by which we can reduce the pain in a woman with dysmenorrhea.